You should be seeing the message shortly. There you go.
Okay, thanks. So good morning, everybody. I want to welcome you all to our Long-Term Care Planning Committee meeting. Just as a reminder, Governor's executive order regarding public meetings is still in place. So this meeting's being recorded and will be posted on the Long-Term Care Planning Committee's website soon after this meeting, which is on the Office of Policy and Management's site. So when you speak, if you could just say your name, that would be appreciated. So why don't we go around first and we'll do introductions. We'll first do planning committee members, and then if guests quickly want to just introduce themselves, that'll be great. Let me see who we have. My name is David Gutchin. I'm the chair of the planning committee from the Office of Policy and Management. I see we have Stephanie from DCF. You want to introduce yourself?
Good morning, everybody. Stephanie Bozak, representing DCF.
Okay, and I see we have Jennifer Cavallero, who I want to welcome to the planning committee from the Department of Social Services. This is her first meeting with us. So Jennifer, welcome.
Thank you. Good morning.
Margie, do you want to introduce yourself?
Good morning, Margie Gerando Marquette. I'm with the Department of Aging and Disability Services in the State Unit on Aging.
Thanks, Margie. I see we have Kelly. Kelly, do you want to introduce yourself?
Sorry. Good morning. I'm Kelly Kendall, representing the Department of Developmental Services.
And Erin from DEMIS, do you want to introduce yourself?
Sure. Good morning, everyone. I'm Erin Livett-Smith. I'm the Director of Long-Term Services and Supports with the Department of Mental Health and Addiction Services.
Okay. Representative Wilson?
Good morning. This is the first time I've dialed in, and I'm looking forward to the conversation. Have a long background with long-term care in Connecticut, and David and I have known each other, I guess, since about 1992.
Yeah. Did I miss any other planning committee members?
Hi, David. This is Amy Porter from Department of Aging and Disability Services.
Hi, Amy. Sorry I missed you. Michael, I see you're there.
Michael Santoro, the Director of Policy Research and Housing Support at the Connecticut Department of Housing.
Thanks, Michael. And I think
Donna
that's
Ortelli.
it.
Donna
Hi,
Ortelli.
Donna.
That's okay. I'm sorry. Donna Ortelli. Good morning, everyone. Representing Department of Public Health.
Thanks, Donna. It's hard to see everybody on the screen. And Melissa, do you want to introduce yourself?
Sure. Melissa Morton. I'm staff to the Long-Term Planning Committee with the Office of Policy and Management.
Okay, and he's not a planning committee member, but I would be remiss since he is my new supervisor. I see that Claudio Gottileri has joined us. Claudio, are you there?
Yeah, hi, David. Claudio Gualtieri, Undersecretary of Health and Human Services. Great to see this group. This always feels like home. So many important players that have done such great work to look at our long-term care system, especially now with COVID shining a deep light on some of the system changes we need to do. It's great, Representative Wilson, to have you here and to lend your attention to these important issues and all the dedicated people who have laid the groundwork. And I think we're just getting to the point where the feds and are actually recognizing and putting some money behind strengthening our long-term care system. So exciting time, and thank you, David.
Thanks for joining us, Claudia. And I think, Jessica, did you introduce yourself?
No, not yet. My name is Jessica Rival. I'm with the Office of Health Strategy.
Okay, I think that's all the planning committee members. Before other folks introduce themselves, I just wanted to point out, because there has been some confusion, there are two bodies in statute that are dealing with long-term care planning. The first is what we just introduced here, which is the Long-Term Care Planning Committee, which is what this meeting is for. And the Planning Committee is comprised of representatives from 10 state agencies and then 12 legislators, which are the co-chairs and ranking members from the Aging, Human Services, and Public Health Committees. And then in a separate statute, there is the Long-Term Care Advisory Council, as important a body, but a separate body in statute that was developed to provide advice and recommendations to the Planning Committee. And many of the Advisory Council members are with us, and you can introduce yourself, but they are two separate bodies. Sometimes people are getting confused, especially there are some new members to the Advisory Council. So I just wanted to point that out to folks. So if others want to introduce themselves, let me see who's here. Matt Barrett, are you here?
Yeah, good morning, David. It's Matt Barrett from the Connecticut Healthcare Facilities and the Connecticut Center for Assisted Living, and a member of the Advisory Committee.
Thanks. And I see a Jay Katz. Jay? Okay. And Stephen Hernandez, are you here from the commission?
Good morning, everyone. Steve Hernandez from the Legislature's Nonpartisan Commission.
Thanks, Stephen. Anna, are you here from AARP?
I am. Good morning. I'm Anna Dorgazi. I'm one of the policy directors at AARP Connecticut, coming to you from Claudio's old office.
Thanks, Anna.
Lots of good ideas started there, Anna. Thank you for continuing that good thought process.
I see Deb McNaught. Deb, are you here?
Hi, good morning. Good to see everybody. Deb McNaught from UConn Center on Aging.
Hey, Deb. And Christy Koval from the Alzheimer's Association.
Good morning, everybody. Christy Koval, the policy director with the Alzheimer's Association Connecticut chapter. Nice to see you today.
Hey, Christy, thanks for joining us. Lauren Carabetta.
Good morning. I'm Lauren Carabetta. I am a program manager in the Msp strategy group with DSS.
Hey, Lauren. And Brian Sullivan.
Brian Sullivan with Prisby and Associates, Government Affairs. Thank you.
Hi, Brian. And Andre Brell. Andre?
Yeah, good morning. My name is Andre Brell. I represent Connecticut Association of Adult Day Services today. Thank you.
Okay. And I see a 914 number.
David, it's Karen Buckley from CHA. I'm not sure if that's my number, but I am on the phone calling.
Okay. Thanks, Karen. And then we have some special guests from DSS who will be presenting today. Dawn Lambert. Dawn.
Morning, Dawn Lambert, DSS, co-lead community options with Jennifer Cavallaro. Happy to be here.
All right. And Carrie, I see you're here.
Good morning, everyone. My name is Carrie Fillick. I work with the Department of Social Services with the Community Options Strategy Unit.
Okay. And I see Laura Watson just joined us from DOH. Laura?
Hi, everyone. It's Laura Watson. I work with Michael over at the Department of Housing.
Great. Did I miss anybody?
David, it's Marie Painter, the State Long-Term Care Ombudsman.
Hey, Murray. Thanks for joining us. Anybody else? Okay, well, thank you all for joining us. This is quite a group. So it's been a great meeting, and hope you have all have a good day. So sorry about that. So let's move on with the agenda. So the first item is an update on legislative action related to long-term services and supports issues in the last legislative session. And I'll turn this over to Melissa Morton, who will give us a summary of the update. The update will be posted on the Planning Committee website after the meeting. So Melissa, I'll turn it over to you.
Sure. So thanks, David, and welcome everybody. At our meeting in June, I did run through the highlights of the 2021 legislative session. However, the one piece that was missing was that we were still waiting on what the budget implementer was going to look like. So since our last meeting, we were able to update the legislative summary to include updates on key provisions of the budget implementer. We are currently finalizing that, and by the end of the day today, you will be able to log onto the Long-Term Care Planning Committee website and view the legislative summary that now includes the dates at which the governor signed all of the bills that we reviewed in June, and the summary of the budget implementer. And as in past years, please, if you see anything that we missed that you think should be included in the budget, in the legislative summary as it pertains to long-term services and supports, please feel free to email David and I will make sure to update the summary accordingly. David, did you want me to actually go through the budget implementer updates, or? Oh, you're muted, David.
No, I don't think that's necessary. I think the summary will provide ample details on that. I did want to mention one thing. I think we mentioned this at the last meeting. It's related to a bill dealing with long-term care insurance, which was Senate Bill 1046, that was ultimately signed by the governor. The most important thing that bill did was limit the ability of insurance companies to stack premium rate increases on each other. Currently, our insurance department allows insurance companies to get multiple rate increase approvals during the 3-year period where they have to implement increases of 20% or more. And it results in a stacking of rate increases that has had an extremely negative impact on long-term care insurance policyholders. Current law requires that any rate increase of 20% or more has to be spread out over 3 years. And the intent of that legislation, which was passed several years ago, was to limit the amount of increase on in any given year on a policyholder. But during that 3-year period, insurance companies could come in and ask for additional rate increases on the same insurance policy And that stacking effect really has a detrimental effect on policyholders. So starting with rate filings effective January 1st, 2022, an insurance company cannot ask for an additional rate increase until they finish that 3-year implementation period. Personally, I think it's a significant change. The insurance department is very supportive of it. They felt they didn't have the authority to disallow the stacking of rate increases. And so now the legislature has prohibited that practice. It doesn't put a cap on rate increases. That is something that advocates have been pushing for, but this is a good first step, at least in my opinion, to helping out long-term care insurance policies, especially as they get older. So any questions on that? Okay, the next item has to do with the long-term services and supports plan that you all know we're in the process of developing and have to submit to the legislature by January 1st, 2022. This is the 3-year plan that the planning committee is charged with doing. And I want to thank everybody, both on the planning committee and the advisory council, who have provided us input on recommendations from the past plan, as well as new recommendations for the new plan going forward. And I want to turn it over to Melissa because she has done some great work recently putting together, with the help of other entities such as Anna at AARP, on listening sessions to get feedback from folks, as well as collecting all the feedback that we've received to date, which will then be compiled and provided to folks. So Melissa, I'll turn it back over to you.
Great, thanks, David. So I want to echo David's thanks. I know the state agencies are incredibly busy and stretched very thin, and I appreciate everybody's timely submission of updates and recommendations for the 2022 long-term services and supports plan. We had a great response this year from the state agencies. Just a quick reminder that all of the updates, which consist of 3 different documents for Appendix G of the Long-Term Services and Supports Plan, are due next week, September 24th. And those 3 updates include just asking that the state agencies please review their state agency descriptions, make sure that those are still accurate, and send me any updates. We also have the 2 spreadsheets that you're used to completing every 3 years. The first is an expenditure spreadsheet that asks for some financial information regarding state agency programs that we include in the plan. And the other one is regarding consumer data and general programmatic statistics. So just throwing it out there as a reminder, because that is a critical part of our plan, so that date is coming up September 24th. So as David alluded to, this year we branched out a little bit and tried to really gather direct consumer feedback from the individuals who are utilizing the services and supports. We have done, I think, a really good job in the past of getting feedback, much in thanks to our partners at the Long-Term Care Advisory Committee, of being able to get feedback from advocacy organizations and direct service and community-based organizations that work directly with consumers. But where we identified a place we could probably do a little better is trying to gather direct feedback on some recommendations for the plan from the individuals who use the long-term services and supports directly. So this year, for the first time, we developed a feedback survey that was specifically designed to go out to consumers. And the survey, which I will be happy to circulate to everybody, and I think I might even have a link to it that I'll post in the chat when I'm done presenting, was we asked community organizations to please send the survey out via listservs and other entity ways that they might have to reach their consumers. We got a much better response to that survey than I expected. I will say particularly we heard a great deal from the IDDD community. I think that once the email went out from the ARC, we started to get a great number of surveys back. We also partnered with AARP, who was doing their own survey. They added a question to their survey and are gathering feedback for us through that channel as well. So that's the first new thing that we did this year. The second thing we did is we piloted the idea of holding listening sessions to get direct consumer feedback on long-term services and supports. We are starting small this year because the idea came a little late in the game, and also wanted to see if it would bear any fruit before trying to do anything on a larger scale. So 2 listening sessions have been held so far. We purposely tried to target certain populations of individuals utilizing long-term services and supports. So we looked at aging services, we looked at the developmental disability community, and then also looking for the first time this year to really try and focus more on health equity and how can we better address concerns of health equity in the long-term services and supports plan. And so we are partnering with our friends at Health Equity Solutions to try and get a third focus group together to address those issues and get feedback on how the system can better address historically underserved populations. We held the one with the ARC and with AARP through much assistance from Anna last week. We had a total between the 2 groups of, I believe we had 15 individuals. They were fantastic. I have to say that people were forthcoming. We used the survey as a guide, but it was very conversational. And I don't want to take up too much time, but I thought it would be interesting to share with you some of the themes that came out of the listening sessions and that we have held so far, as well as the surveys. The themes were pretty general, and we really heard overlapping concerns across the system. They might have used different state agency names and facility names, but the concerns were pretty much the same. So themes that we heard were access to services. People were saying that they, didn't know what services were available to them or even how to find services. They didn't know how to enter the service system. And then once in the service system, you know, if they got connected to DDS services or DSS services or even community-based services, that they had no idea what, as the needs of their loved ones changed. And I will say that 100% of people who participated in the listening sessions were in fact either parents or informal caregivers. And I would say universally, everybody said the system was not nimble and not good at timely changing care plans to meet individual needs. So we did hear about that. And actually one thing that came up in both was also, and in some surveys, was that people were having difficulty accessing hospice services. So education and outreach was another theme, making individuals in Connecticut aware of the services that are available to them and how to access them. Assessment was a key concern that came up across all populations, that people felt the assessment process was shrouded in a veil of secrecy. They didn't understand how the assessment correlated to their care plans. They felt like it didn't take into account total person and was looking at pieces of people. and not very flexible as needs changed. Quality assurance was another issue. They said that the state is doing a great job in terms of quality assurance when it comes to checking off boxes, such as are buildings up to fire code, are PCAs or workers at group homes showing up and providing the correct number of hours, is medication being given at the right times, but not doing as good of a job at making sure that these staff are well trained and actually engaging with the individuals and not just sitting there on their cell phones. And are they actually meeting the psychosocial needs of their consumers as well? So they felt that the actual quality of the service providers themselves was not being as well monitored as it could be. And expanding, they felt that the long-term care ombudsman program has been extremely helpful during COVID for individuals living in facilities, but they felt that there weren't enough long-term care ombudsmen. And they also felt that once their loved ones went back to the community, they didn't know who to call or rely on to fill that advocacy hole that the ombudsman was helping them with in the nursing home. So definitely people wanted to see an increase in quality assurance and a bolstering of the ombudsman program, both in facilities and in the community. Housing was a huge one, a need for supportive, accessible housing, but in the communities where the individual lives, so they're not forced to abandon their informal networks. And also the need when placing in group homes and other living situations that the individual, that there's some kind of effort made to make sure that the people being placed together gel, and it's not just sticking people in the first available slot for housing. Transportation, this is our perennial issue as well, particularly people we heard from who lived in rural communities in Connecticut were saying, you know, it's impossible to have any kind of community inclusion if somebody doesn't live on a bus line. Employment, this was interesting, was that this one came out of mostly the surveys and the listening session with individuals with developmental disabilities. Felt that one recommendation would be to do a better job fitting people with employment opportunities that meet their strengths and not just putting them in the first job. You know, stacking shelves at a grocery store was an example that kept getting used, when maybe the person would like something more social and would be a better being a ticket taker at a movie theater, doing better matching of services. And also having somebody on the job site who can actually help expand their skill set and not just come in and check off. They felt that people were coming in and just checking off checklists once a week or so to make sure somebody was, you know, showing up at work and doing their job, but there was no training, no making sure the person was happy. And they felt that that could really sustain somebody in the workplace if they had better supervision and more skills training. Backup planning was a huge, huge issue raised by people in both focus groups and very loudly raised in the surveys, where anybody self-directing was incredibly concerned about backup planning, felt they did not have solid backup plans in place, and had no idea what would happen to their loved one if their informal caregiver got sick or was suddenly unavailable. They did not feel they had a good backup plan and that in place to fill the care need or to serve as a authorized representative for the individual receiving the services. So that was one where people wanted to see us focus more on making sure there's backup plans for individuals in our self-directed programs. Workforce development, I would say across surveys and focus groups, this was huge. People are having a very hard time, as we all know, finding personal care attendants and even finding paid agency-based services. they just can't find them. And they said, you know, even if we were to pay $1 million, the bodies just aren't there. I think that's a problem we are all aware of, but that was something people said we really need to incentivize people to want to work at long-term care facilities and want to provide home care services, either as self-directed PCAs or agency-based. The other interesting thing that came up in here was there was very loud voices that not everybody wants to self-direct or can self-direct, and that they wanted more access to PCA, a combination of services through agency-based PCAs, that they felt that would lift an enormous burden. And right now they feel like they have to choose either between no flexibility in care at all or self-direction, and that there's a small program that'll allow people to do something in the middle, but that needs to be an equal viable option. Financing, there was a call to revisit the spousal assessment, particularly for younger spouses of users of the long-term services as a support system, that it's incredibly devastating for a spouse who's younger, particularly under the age of 65, to have to give up half their assets. And then they really, this came up in both focus groups, that one of the things that came out of COVID was that really looking at Medicaid or the state, somebody reimbursing paid caregivers to be allowed to visit individuals when they go into the hospital or another institutional setting, that often these are the people that the consumer relies on, and to go into a hospital or institutional setting and be completely cut off from their support system is devastating. And also a lot of times the parents and informal caregivers were sharing with us that those paid caregivers are part of looking at the needs of the individual, particularly if that individual cannot speak up for themselves, and that really there needs to be some mechanism so that they don't just get cut off from the PCA or caregiver that they've been relying on, simply because the individual can't get paid for their time. So looking at something innovative around that. Informal caregiver support was a huge theme across all populations. The aging group was specifically vocal about the Federal Essential Caregiver Act in the state of Connecticut, looking at that language and adopting it in the state of Connecticut because it was developed with feedback from caregivers. And also populations shared that COVID taught them many lessons. And one was that informal caregivers were completely shut out of being able to provide care and social and emotional support to their loved ones while in the hospital, institutionalized. And one of their very firm recommendations was the state take immediate action to make sure nothing like that ever happens again, and that informal caregivers always have access to their loved one when they, regardless of what is going on, pandemic or otherwise, that they can get in there and provide support and be a spokesperson. Lots of concerns about individuals in nursing homes and hospitals who experience failure to thrive and passed away due to that. So those were the themes that came out most clearly and across all populations for us to think about when developing recommendations for the next plan. I plan on having draft recommendations for everybody to review that will include this feedback from the state agencies, get that out to everybody for review and comment during the month of October so that we can have, I'll be asking for any edits you may have so that we can get you final draft in November and then be able to review the full and completed report at our December 14th meeting, because this is due January 1st to the legislature. I think when you hear I'm not sure what DSS is going to present on today, but knowing some of the exciting rebalancing initiatives that are coming up, particularly, you know, some of the new ones through additional ARPA funding that the American Rescue Act plan funding that the state is receiving, as well as the CHESS initiative and other rebalancing initiatives. I think what's exciting is how some of the themes that are areas for improvement that we heard from the community, we do have some programs coming up to address those systemic gaps. So, I think this is an exciting time for long-term services and supports, and I'm hoping that we come out with a plan that is, very dynamic and able to actually address some of these consumer concerns. The next step will also be that I'm meeting with various partners who work with health equity solutions to help us frame issues around health equity. So that is it for my update. Sorry to go on so long, but they were very meaty listening sessions and very detailed survey feedback that came in from our consumer population.
Thanks a lot, Melissa. Does anybody have any questions or comments for Melissa? Okay, and I don't say this just because he's my boss, but we do want to thank Claudio because it was his suggestion for us to explore the listening sessions this go around, and it's good to get a fresh face and look on things, since Melissa was a child when I started working on the planning committee back when we were authorized in statute in 1998. Sorry, I'm dating myself or Melissa, but anyway, I also want to give special thanks to Christy Colville, Stephen Hernandez, and Michael Warner from the Long-Term Care Advisory Council. As we've done in the past, we are developing this plan as a true partnership with the Advisory Council. So as Melissa said, we'll be sharing the recommendations and drafts of the plan, not only with the planning committee, but with the Advisory Council. And I appreciate everybody's help on the Advisory Council in continuing to work on this, not just as if this is something in the background for them, but something that they are truly part of. And Christy, Stephen, and Michael have been very helpful in terms of soliciting feedback from Advisory Council members and really regenerating that body, because many of you know that it sort of went into a hiatus for a little while, but this is really a good opportunity to resurrect it and get it vital, because the planning committee, as I mentioned earlier, is really just the perspective from the executive and legislative branch. The Advisory Council was meant to get the perspective from the folks who are really in the trenches of the long-term services and supports community, both from a provider, advocate, folks with needs for long-term services and supports, family members, and so on. And so without that input, we don't get as broad a perspective as we really need to, which is important to provide a comprehensive plan for the state. So with that, we're going to move on to the Department of Social Services, Long-Term Services and Supports Rebalancing update. Folks probably know every September, Dawn Lambert and her very talented team at DSS are gracious enough to give us a presentation on their rebalancing efforts. And as Melissa said, I think this year is extremely timely, not only because of all the initiatives that are going on, but obviously because we're in the process of putting a plan together. So I think there is some good symmetry going on. So without further ado, I'll pass it off to Dawn and her team. So Dawn, thank you.
Thanks, David. And at the risk of dating myself, aligned with what David was talking about, I'm here this morning with two newest managers to the strategy group in community options, Carrie Philick and Laura Carabetta, who also were probably somewhere in school around about 1998. And it was about 2 years later when David and I started to work together just after the Olmsted decision. And that's when the real systems change grants were funded. And since that time, we collectively, including the ARPA funding, have brought to the state of Connecticut over $850 million of new federal resources to continue to make change aligned with advancing choice for people to have options in the community in lieu of institutionalization. So $850 million later, David, we're here bringing some life to various initiatives aligned with the Long-Term Care Planning Committee objectives. And thanks for putting together all those listening groups, Melissa. It's really important to have ongoing stakeholdering. We believe fundamentally in that and have done so since 2000. If we don't listen to the people that we serve and the people who are actually in the community, then I think that we'll get it wrong every time. So thanks a lot for doing that. Carrie, do you want to just put up the presentation while we transition to the slides? So this morning, we are going to go through a pretty robust deck, 38 slides. We're going to do it quickly. We'll let the committee know and anybody else who's listening in that at the end of the deck, there's more information on many of the things that we're going to highlight at a very high level. We want to make sure that the committee was briefed on a lot of the work that's occurred over the last 365 days. Even in the middle of the public health emergency, we were able to advance many of the initiatives that we had planned to do so. And in addition to bringing in a couple of more $1 million for the state, including an extra $5 million for MFP. And you'll be hearing a little bit about that this morning, too, in terms of what's called capacity building. We will, if it's okay with everybody, we'll save questions for the end. And once again, at the end of the deck, there's a lot more information if you'd like to see it on things specifically like ARPA, which right now in this presentation, we only have one slide on ARPA, which is the American Rescue Plan Act. That's the newest funding coming to the state, just on the heels of an additional $5 million for Money Follows the Person. So next slide, please, Carrie. So I already did review quickly. You're going to hear, and Melissa had to ask for certain things. These are the things that we in the strategy group worked on over the past year. You will see in next year's presentation many, many, many more as we continue the work on the American Rescue Act plan and as we implement capacity building. Also, the other new initiatives like CHESS that we just launched officially last week. Next slide, please. I've already introduced us, so next slide. So the American Rescue Plan Act was funded by Congress for two primary reasons, and those two primary reasons are for the state to address the impacts on the community long-term supports and service on long-term supports and services in the community as a result of COVID-19. That's number one purpose. The number two purpose was overall rebalancing of long-term supports and services, which we've been engaged in Connecticut since the year 2000. We were very well positioned when this was announced as administered by CMS. I will say that the actual administration is in the systems transformation group of the federal government, of the CMS, which is the group that we've been working with for the past now over 20 years on initiatives like Money Follows the Person Balancing Incentive Program and now ARPA. So we're very familiar with the staff there. In many cases, they've also been there for 20 years. So we're excited about moving forward in partnership with them and familiar with a lot of the reporting and the way that we can create synergy, because the team at CMS also believes in these things. So it's a real partnership with CMS as well. So once again, ARPA was funded for two primary reasons. One is to address any weaknesses in the system or that may have emerged as a result of COVID-19, and also for overall rebalancing efforts. And our plan was very much, our submission to the federal government was a request just over $500 million. And that request was really framed already by the strategic rebalancing plan, informed by the long-term care planning committee work. So there's alignment and we were well positioned to do this. Next slide, please. At a very high level, here are some of the things that are included in the American Rescue Plan Act. And this is Department of Social Services. I will say that DEMIS also has some initiatives funded by ARPA as well as Department of Developmental Services. And so you might hear about those or ask to hear a little bit more about those in future meetings. For DSS, the major initiatives to highlight, one is that we have expanded benefits for Medicare Savings Program participants. And that expanded benefit includes supports for informal caregivers. It includes support for environmental modifications, for assistive technology, and for case management. We're very excited about the opportunity to be able to provide an additional benefit for Medicare Savings Program participants. So that's the eligibility group. And of course, it will be aligned with the needs of the individuals, but that will be something new that we develop and that we hope to be implementing definitely within the next 6 months. We have various workforce initiatives. As I mentioned, ARPA was for two primary reasons. One, to address weaknesses in community LTSS as a result of the public health emergency. And the other one was general rebalancing. We have thousands more people in the community now than we did in March 1st of 2020, prior to the public health emergency. And many of those people are being supported by informal caregivers. And so, and of course, the others by the direct workforce. We all know about the workforce shortages. They've been something that we have talked about for 20 years. It's nothing new, but it is definitely more urgent now to address the rates and to stabilize the direct workforce than it was before. So a lot of these things didn't become important necessarily because of no COVID-19, but became more important. So because of that, there will be provider increases that were funded under ARPA and will be rolling out to community long-term support and service providers funded under the various authorities of the federal government and operated by the Department of Social Services. There are also going to be retention and recruitment bonuses, hoping to attract more workers to the direct support roles that are so important to the members and the people that we serve. I already mentioned informal caregiver support, anything from, and once again, this includes Medicare Savings Benefit Program participants, anything from assistance with training, to counseling, to supports for respite, to additional supports from an occupational therapist that's trained. We have 2 initiatives rolling out for informal caregivers. Once again, supports for informal caregivers. This is literally a service for the informal caregiver so that they can provide support to the member. And we have not done that previously in the state of Connecticut outside of respite. We have had respite, but we have not had direct supports for informal caregivers for the DSS long-term supports and service community waivers or 1959s or case. Assistive technology, we do hope to modernize, and there's $40 million. I know that Steve helped me, Mike helped me a little bit. Mike Santoro, I see from DOH, had that emergency call as we were trying to draft the ARPA proposal to say, what can we do to help with housing? And we got some immediate feedback on how we might be able to modernize some of the existing subsidized housing. And so we do have funding, $40 million, as I mentioned, to help modernize some of the existing subsidized housing that will roll out in a NOFA or RFP for the various facilities. And we'll be working with Mike on that, and we look forward to doing that. We're also going to be increasing the use and training for assistive technology across all community LTSS. Incredibly important. We've had assistive technology for years, but it is underutilized in community. And based on what we learned from COVID-19, I think we all learned, as evidenced by this meeting, which is virtual, how much more important virtual technology became. And we need to do better with respect to helping members who would benefit from and would like to have more assistive technology embedded in their service plans to increase their sense of autonomy and also independence. The last two things I want to touch on, model design. This model design will be a new delivery system of community supports. We'll be working with communities to develop it, and there will be a specific focus on improved backup systems. So to Melissa's point about individuals saying, hey, we need more backup systems. And I will say sometimes backup systems is the reason that people don't have a choice to remain or to move to the community. We need to do a little bit better. And this model design will be seeking innovation and improving the backup systems that people will have access to in community supports and service. And then the last one, quality initiatives. Quality is important for everything that we do. There's a significant investment, and I know this was very important to the folks at the Office of Policy and Management as well, to make sure that we do more in terms of quality services and improving quality. There will be three primary things that we do for under quality. One is that we are going to be seeking innovative proposals to improve quality from stakeholders in the community. And we look forward to rewarding those proposals and implementing them. We know that at the Department of Social Services, we don't always have the best ideas, and that frankly, the best ideas very often come from people who provide services or people who receive services themselves. So we want to get them involved and hear their ideas and see how we can raise those ideas up and implement them in a permanent way in our community supports and service system in order to improve quality overall. We also have a new package of services that will be developed, or a toolkit that will be developed for the members that we serve, empowering them with information so that they can better self-advocate for themselves and then improve the quality of the services that they receive. The best folks that can monitor what's happening are those that are empowered in their household to understand not only what quality should look like, but also who they call if they feel that that quality is not being delivered. So with that in mind, the very last thing, there is a pay for performance value-based incentive. That part of that in year one will be directed at providers who, if they participate in racial equity training, once again, the health equity lens, that if they participate in training as well as they enroll with the health information exchange to start to become more familiar with the data that's there, that they will be eligible for a pay for performance. And you'll be hearing more about that as the next couple of months emerge, because the department feels pretty strongly that if we create the right incentives to help guide provider behavior in a way that's aligned with improved outcomes for members, that will also help improve quality. So with that, let me turn it over to Lara, who is going to go ahead and, Lauren, sorry, who is going to go ahead and talk a little bit about the capacity building. Lauren?
Thank you, Dawn. Next slide, please. So as Dawn mentioned, our next topic here is our capacity building plan. And our capacity building plan has two primary objectives. One is to increase the use of home and community-based rather than institutional long-term care services. And the other is to increase the availability of self-directed services and supports beyond MSP participants. Next slide. For our first objective related to Hcbs services, we'll have 10 staff co-located in nursing homes. These staff members will be providing Hcbs information to people who are at risk for staying in a nursing home for more than 100 days, and more specifically, Medicare Savings Program participants who are not yet eligible for Medicaid. Care management staff will offer choice and work to facilitate transitions, ultimately leading to the projected outcome of an additional 600 people returning to the community. This is connected to our MyCare Options initiative with the intention of increasing the percentage of people who are receiving their first long-term service and support in the community instead of a nursing home. And this will help people glide from Medicare to Medicaid while in the community. Next slide. For our second objective related to self-direction supports, we will be increasing the number of support and planning coaches, and we will also increase self-direction tools and training options. Next slide. Our next topic is a brief update on our Msp Benchmark. Next slide. We will review updates on our 5 benchmarks, which all of you are pretty familiar with, I believe. And I just ask you to please keep in mind that the benchmark graphics and data that you will see are based on the latest data available at the end of the quarter. Next slide. Our first benchmark, of course, is related to the number of transitions from institutions to the community. The total number of transitions is 6,816. So we continue to exceed this benchmark. Next slide. Our second benchmark is to increase dollars to home and community-based services. You can see that the line graph indicates that 54% of Connecticut's Medicaid long-term care expenditures were spent on home and community care compared to the 46% spent on institutional care. Next slide. Our third benchmark is to increase hospital discharges to the community rather than to institutions. The line graph indicates 66% of hospital discharges were to home and community care, with 34% of discharges to skilled nursing facilities. Next slide. Our fourth benchmark is to increase the probability of returning to the community during the 6 months following nursing home admission. The bar graph below shows 35% of people who were admitted to a nursing facility returned to the community within 6 months. So we continue to work on this benchmark. Next slide. Our fifth benchmark is long-term care participants living in the community compared to an institution. And the line graph here depicts that 65% of people receiving long-term services and supports are receiving those services in the community. Next slide. People who participate in the program, they report out on their happiness with the way that they live their lives after they transition into the community. And you can see here that more than 80% of people report being happy with the way that they live their lives, which is really, really important to us. Next slide. Our next topic is going to be some updates about the universal assessment. Next slide. The updates on the universal assessment tool are related to both expansion and improvement. And in terms of expansion, we'll be working to expand the utilization of the UA to participants who are receiving services from both CDS and the Department of Mental Health and Addiction Services. In terms of improvement, we'll be conducting a comprehensive review of the UA and identifying opportunities for improvements. And as you know, the UA utilizes an algorithm to determine the level of need and level of care with an individual. And we will be working to establish need groupings that are associated with care plan budget allocations to ultimately ensure cost neutrality and supportive services. Next, I'll hand it over to Carrie and move on to our next topic of community first choice.
Thank you, Lauren. Okay, so I'll be talking about community first choice for the next few minutes. And just as a refresher, community first choice is a home and community-based services Medicaid entitlement for people who meet the functional level of care. What that means is that people who are active on Husky A, Husky C, or Husky D can't access community first choice. CFC, as we call it, is a self-directed program, allowing a person to name and hire their own personal care attendants, their PCAs, and then to set their own schedule. CFC continues to support people in the community with almost 5,000 people receiving services at home. If you look at this chart quickly, we've just broken it down by the total number of people receiving services, and then we broke it down by waivers, and then each individual waiver, our Medicaid waivers that we have in the state of Connecticut. And just if you look at the graph on the right, the acquired brain injury waivers 1 and 2, the personal care attendant waivers, waiver, the Connecticut home care program for elders at CHCPE, our DDS waivers, Department of Developmental Services, and then autism. And as we continue to navigate through community first choice, or through COVID-19, community first choice still seems to be a popular option for people living in the community. I just took a quick average of our applications that we've received for the program over the last 6 months, and these are the exact numbers. So we're still receiving over about 200 or more applications per month for community first choice. We have a lot of people interested in the program. I just want to talk about briefly some things that we presented at last year's committee and what we continue to support in the community for our individuals as we still navigate through and manage COVID-19, the public health emergency. As at the time of the declaration of the public health emergency, DSS put in place some guidelines, response guidelines for CFC. Some of that included expedited onboarding process of new CFC participants or employers of record and PCAs, and that's coordinating with Allied, our fiduciary. We've also put in place emergency hiring of PCA staff for existing CFC participants, overtime hours for existing PCA staff, temporary budget increases for existing CFC cases, and then a temporary suspension on CFC budget reductions. All of these measures are still in place. We continue to support individuals in the community through the public health emergency response. And by authorizing these services or allowing for these services or provisions to be put in place, we've shifted the authority to our access agencies. And this allows our access agencies to authorize immediate services. So there's no delay, so we can get people moving through the process and the steps that they need to either receive services for the first time or to continue to receive services without any gaps in coverage. There's no additional approval needed by DSS, but there is needed by the access agencies. And again, this is just aligned with the declaration of the public health emergency. Next is our Connecticut Housing Engagement and Support Services Program. Dawn briefly mentioned it earlier in the presentation, what we call CHESS. It's a new program that actually just launched last week. I'll go through some CHESS slides now. CHESS, it's also home and community-based services Medicaid entitlement for people who also meet the additional requirements for CHESS. And what that means is anybody who's accessing Husky A, C, or D as their Medicaid program benefit can access CHESS as long as they meet those requirements. CHESS, it's built upon the history, the combined work history of multiple state agencies. We've worked with the Department of Housing and currently with the CANs, which are Coordinated Access Networks, the CANs and the housing subsidies that are offered to people in the state, the Department of Mental Health and Addiction Services, the Supportive Housing Program that is authorized through DMIS, and then currently with DSS, MFP, what we've learned from some of our programs with Medicaid services and wrapping it around with housing supports, what we call Housing Plus supports. CHESS combines all of those services. It combines Medicaid services, both new and current services, supportive housing provider benefits, and then non-Medicaid housing subsidies. And the goal of CHESS, it's really to achieve housing stability for the member, improved health and community integration and life satisfaction for the person in CHESS. These are some of our requirements for CHESS, and a person would need to meet all of these requirements. I just mentioned a person would have to be active on Husky A, C, or D, be 18 years or older. And now here's more of the technical requirements. Have a behavioral health diagnosis. And then additionally, the person must meet the needs-based criteria. And there's 3 components of the needs-based criteria. The first is homeless or at risk of homelessness. And when we talk about being at risk of homelessness, it's at risk of homelessness without receipt of CHESS services. And I'll talk about that in a little bit. A person would have to have a modified Carlson Comorbidity Index score of 4 or more. And what that actually means is it looks at a person's current diagnoses and how sick they might be in the future. And that's where we get this number. It's an algorithm. And then to have at least 2 critical needs. And critical needs could be help with maintaining housing, help with behavioral health management or healthcare coordination, but they could also mean help with activities of daily living, ADLs, and instrumental activities of daily living, IADLs. There's 4 main service components of CHESS. The first one is care plan development and monitoring. The next one is pre-tenancy supports. The next is tenancy sustaining supports, and then there's non-medical transportation. Within each of these services, so these are the 4 broad services, there's many activities within pre-tenancy and tenancy that our staff can use to support the person in the community. Ultimately, with these services, what we're hoping to do is help a person identify their goals and how to be successful in the community. And obviously a big component of CHESS is supporting through subsidized housing. So locating housing but helping that person become an active tenant now and helping them maintain residency in the community, but also helping them engage and become an active member in their own healthcare and behavioral healthcare coordination, and then to supporting that individual and helping them sustain that through their life in the community. It's through these services, these 4 service components, that we hope to achieve those objectives and goals. I want to quickly talk about all the different people working on CHESS. There's the Department of Social Services, some of our staff on the phone today, and we have some staff in central office who will help determine CHESS eligibility, financial eligibility processing, so that relates to Medicaid, and doing some technical things in our systems like entering start and stop dates and working with our behavioral health administrative service organization, which that's another huge partner with us is our behavioral health ASO, Beacon. Beacon will complete the universal assessment, complete data review processes for CHESS application, review and approve our person-centered recovery plan and our revised plan. So that goes back to one of the services. So each individual under the care planning component will have a person-centered recovery plan. And as all programs at DSS are completing annual reassessments, and then prior authorizations, which relates to billing and payment for our supportive housing providers. And we are contracting with our supportive housing providers. We're currently and actively enrolling members as Medicaid providers. With that, our housing providers will complete our housing assessment, which we also call the acuity index. They'll be the individual completing the person-centered recovery plan, so working with the CHESS member, submitting prior authorizations, and that's again related to billing and claiming, helping the member locate and secure housing, completing the revised plan, and then the actual direct service delivery. So that goes back to tenancy sustaining and the pre-tenancy supports that I talked about earlier. CMS, we got official approval on August 16th. Right here, these links. So if you're reviewing this presentation later on today, both of these links, you can click on them. The first one is the press release from Governor Lamont. And the second is an article that was recently published by the Milbank Memorial Fund that discusses CHESS as part of Connecticut's long-term services and supports program. We are accepting, and we have been accepting online applications, ctchessdss.com for an individual to submit an application. And then a person could also call this number or 211 for more information on how to apply or more information on the program. Next, I'll talk about My Place CT transition and the work that we've been doing on this website. So last year we presented on myplacect.org, which is the virtual home of the No Wrong Door. It contains all information on long-term services and supports in the state of Connecticut, regardless of payer source. It's a resource for people, anybody in Connecticut or in the community to learn about what services are provided in the state and then what could possibly be available to help support a person, whether we discuss, is this something that Medicaid might provide or a benefit that might be provided under long-term care insurance. So there's a lot of great information here. Last September, we actually moved to a new partner marketing firm called O'Donnell, who had continued the work on My Place CT. We recently went, there's a revamp of the website. This is what it looks like now. It's beautiful. It continues to be user-friendly. A great feature on the website is there's an accessibility button to help make the website more accessible for people, whether it's changing the colors, zooming in, focusing on text. So it's a great website overall. With the change in My Place CT and the continued support of O'Donnell, we also have some information available, and this goes back to supporting our capacity building, some of our capacity building initiatives. And these videos and the financial tools that I have referenced here, both of which are links that you could click on later on to access and pull this information up. These have been in the works for the last few years. I want to give a quick shout out to Julie Evans-Starr and Deb McNaught, who we worked on these together and just both put a tremendous amount of work and information behind these two items. The first one is a series of Medicaid informational videos that helps a person in the community understand what Medicaid is, starting at the base of really the difference between Medicaid and Medicare, and then building up to Hcbs Medicaid, which is, I would say it's probably the most complex. There's a lot of asset information and relates to homes and trusts and all that great stuff. The 5-year look back we talk about, it goes through those videos. And then second is our financial tools. And what we've learned over the last few years is that Medicaid is incredibly complex, especially long-term services and supports Medicaid. And we want to try to demystify that and make it more user-friendly for anybody to use and navigate. And that's what we have through these financial tools to help people support the process through a Medicaid application, or just to get some more information in the planning phases for the future. Before I open it up to questions, I just want to mention again, at the end of this presentation, we do have Appendix A, which is our American Rescue Plan Act. It goes over in greater detail what Dawn talked about at the beginning of this presentation. And then the second appendix, it just references our nursing home COVID analysis from last year's presentation and what that looks like. So if you are viewing this later on, please move through those slides, as we have a lot of information towards the end of that PowerPoint. But I will open it up. I'll stop sharing or actually keep my screen up, and I'll open it up to any questions. And Dawn and Lauren, if you'd like to join.
Anybody have any questions or comments? Anybody have any questions?
I think you see Mike's hand. Mike, do you have your?
Not really a question, David. Thank you again, Mike Santoro, Department of Housing. I just wanted to say thank you for all the hard work you guys have done. We are thrilled about the rollout of the CHESS initiative. We're going to be working or trying to help you guys get this implemented as successfully as we can. You know, our primary contact is Steve DeLella, the director of our Individual and Family Support Services Unit. But if you need anything from us, please do not hesitate to ask. We see this as a big win and a huge opportunity. Thank you.
Thanks, Mike. We're really excited to work on the CHESS and with you guys. It's been a great partnership now for many, many, many years with DOH. What's particularly exciting about CHESS is it's the first time that Medicaid healthcare plan is actually addressing a social determinant like housing and integrating housing stability into actually the health benefit. And so that's what's most exciting, is really our first footprint in integration of social determinants. And I think there'll be a lot more in the years to come. So this will be the first. UConn's evaluating. So as always, Deb's somewhere here, I think, in this meeting. And she might have something to add with respect to evaluation.
Hi,
Any
yes.
other-
Yeah, just quick comment, just from UConn. You know, really excited about all of these initiatives, and you know, it's just wonderful to see some of these things that we've been talking about a long time, that everybody on this call has been talking about a long time, to be able to see some of that go into action. So evaluation in particular, a lot of our focus is going to be around evaluation of putting some of these new initiatives into the Medicare Savings Program. That's kind of the new and innovative piece of this that is really exciting, and we'll be sure to be being really evaluating very carefully to be able to look at, you know, effectiveness, cost effectiveness, and also quality, and all of those pieces, so that we can provide you all back with that information for hopefully long-term sustainability, if the outcomes show that that is what if everything is effective and working well. So we're looking forward to that and all the work. And it is a lot of work. Kind of an understatement. Of course, everybody's going through all of this, and I think many of us are with our eyes sort of, that emoji. The emoji with the eyes. Yeah, that's kind of, I think, how we all feel. Excited, but wow, it's a lot. So congratulations to Dawn for putting this plan, getting the approval of this plan. And we look forward to, the partnership and evaluating all of this.
Thanks. Hey, it's been a great partnership with UConn. A lot of what we've done, and everybody here knows this, but for the partnership with UConn, that third-party transparency, and they've always been there right by our side to provide, to kind of dig in. And even as recently as yesterday, I was texting Julie and saying, Julie, can you jump on a call? I have another idea. And she's like, I don't think so. And I could share that string of what that's like, but UConn's always been there. But like I said, but for them, we in the state wouldn't be as far as we are in terms of rebalancing. It's been a great partnership and a great, I think, value add to the university. So I didn't mention UConn. UConn is evaluating CHESS, and they're also embedded in ARPA, in the American Rescue Plan. They're going to be evaluating all those activities, which we have only until March 30th, 2024. All of the things at the end of the deck have to be completed, evaluated, and sustained. So prove that it's effective, prove that it's working, and sustained by 2024. That's a lot. That's a lot of work. So we're up for it. We have the team, and we're really excited.
Any other questions or comments? And I would encourage everybody to read the article from Milbank that's referenced in the slide deck. It really shows the importance of all this work. It's not a long read, but it really highlights how far Connecticut has come thanks to Dawn's leadership and the hard work of a lot of others at DSS. So, as this presentation shows, there's an awful lot of good work going on. And I really want to thank Dawn, Lauren, and Carrie for their presentation, and all the folks on the team back at DSS and all the agencies involved. It's a multi-agency, multi-provider effort in all these initiatives, all within the context of an ongoing pandemic. So quite amazing, all the committed work. I've been doing this for over 30 years, and I'm always amazed at how committed and talented many of the state employees are that are involved in this. I think sometimes state employees get a bad rap, but certainly all the ones I work with when it comes to long-term services and supports are there because they really believe in the work. And I think the citizens of Connecticut are certainly the beneficiaries of that. So I just want to thank everybody. So with that, this is our time on the agenda where any planning committee member, if they have an update or an announcement they want to make, this is your opportunity. So Margie, you usually tell us about money you've gotten, so.
Yes, thank you. So I think in our last meeting, I shared that the State Unit on Aging was going to be receiving both vaccine funds as well as American Rescue Plan funds. And for the update, we did receive those funds. We're working to get them into contracts, including to the area agencies on aging, so they can get those out to the communities. So that's a focus for us right now. So one other update, we did wrap up our Senior Center Adult Day Center project, which we started in December. And that's where we reimburse senior centers and adult day centers up to $2,500 for COVID-related items to assist during the pandemic and as they plan to reopen. So we were really looking to support the important and valuable work that senior centers and adult day centers do. So there were 91 senior centers and 24 adult day centers who applied for and received reimbursement from this project. The total amount of CARES Act funding awarded was $275,000. And I know that's just a small amount of COVID-related funds, but we hear that it's had an impact. And just to give you an idea, there were more than 20 different items that were purchased, and the most frequently purchased ones were like computer-related items, tablets to loan out to members of senior centers, Zoom so they could do virtual meetings and classes. We've heard so much about the value of the technology. Social isolation kits like puzzles, arts and crafts, playing cards, things like that to support people at home. And of course, hand sanitizer, cleaning and disinfecting equipment and masks are very popular, especially with the adult day centers. So we're finishing up our report for this project, and I just wanted to share that. So thanks for letting me give an update.
Thanks, Margie. Any other updates, announcements? Okay, great. So Christy or Stephen, any comments from the advisory council?
Steve, are you on? I don't know if he's still on.
I lost Steve.
Hi, this is Michael from the advisory council. Hi, everyone.
Hi, Michael.
And hi, thank you. I apologize. So, no, we were excited about the LTSS report, the comments that were sent out from some of our members, and we're certainly looking forward to the new updated report. And I'm hoping in the next week or two, or actually in the next week or so, to start planning out our next meeting.
Okay, great. Christy, any other comments or?
It's not a comment for long-term care advisory council, but it's a really good piece of news from Connecticut. I'll just share with you that Connecticut has been a recipient of a core capacity grant, actually at DPH. This is the Bold Infrastructure for Alzheimer's Act. This is a federal piece of legislation that passed in 2018. And Connecticut is now a recipient as of September 30th. The DPH is going to be working with a number of stakeholders, including many of you on the call. And what this is designed to do is it's designed to create a public health infrastructure for Alzheimer's by looking at things like early detection and diagnosis, risk reduction, preventing avoidable hospitalizations, and supporting dementia caregiving. So I asked Amy Marizzi, who is the chronic disease director, if I could share that news, and we're really excited to work with stakeholders on this.
Great, thanks for sharing that. Okay, folks, I believe we have come to the end of the agenda unless anybody else has anything. Okay, so the recording of this meeting will be posted to the Planning Committee website soon after this meeting or tomorrow. And we will also post the legislative update that Melissa had referenced. And I believe it's already there, the DSS presentation is posted on the website. So, and then in addition, as Melissa had mentioned, we'll be sending out soon the summary of the recommendations, and we'll start to send out drafts of the plan to both the planning committee members and advisory council folks. As those of you know who have been involved with this, the plan has a lot of different sections, not just the recommendations, which is clearly the main component of it. But there's a lot of facts and figures in there that have to be put together, and we're in the process of doing that behind the scenes. So eventually you will see a large document to review. But the first step is really to get the feedback on the recommendations and input on that. But there's a lot of details about projections for need for providers and financing and disability issues, and all the information that we get from the state agencies that Melissa had referenced is due back to us on September 24th. So with that, I just need a motion to adjourn the meeting. I'll raise the motion. Can I get a second?
Second.
Second from Michael Santoro. And with that, we are adjourned. Our next meeting is December 14th, but as I mentioned, we'll be in touch numerous times before then, dealing with the plan. So thank you all for participating. I appreciate it. And thanks again to the folks at DSS for their presentation. So everybody have a good day. Thank you.
Thank you.
Thank you, you too.
Bye, everyone.
Thank you.